Helicobacter pylori is a bacterium which infects the stomach of half of the world population. Most of infected patients have chronic gastritis, which remains mostly asymptomatic. Only 10% of infected people will develop a gastric or duodenal ulcer, and 1% a gastric cancer. 1%, it's not a lot, but 1% of half of the world populations represents each year 800,000 deaths from gastric cancer due to Helicobacter pylori. This is a real public health priority. The transmission of this pathogen is human to human in the family and occurs in the first years of life. You catch this bug when you are a child from your mom or your siblings, and there is no animal or environmental reservoir of this infection. And for the treatment for eradicating H. pylori infection, treatments were until recently empirical treatments, including a proton pump inhibitor combined with either a bismuth salt and 2 antibiotics or 3 antibiotics selected among clarithromycin, amoxicillin, levofloxacin, metronidazole, tetracycline, and rifamycin. Only these 6 antibiotics work on this bacterium. The treatment heals peptic ulcers and prevents their recurrence, and it prevents gastric cancer, but resistance to antibiotics used in this eradication therapy is the leading cause of treatment failure. And the resistance of H. pylori to antibiotics has increased since the discovery of this bacterium, reaching about 20% for clarithromycin, 50% for metronidazole, and 20% for levofloxacin. The resistance of H. pylori to antibiotics is therefore a real public health problem, and the WHO has identified the resistance of H. pylori to clarithromycin in the list of the high priority bacteria for the research and development of effective treatments. And now, due to this high antibiotic resistance and empirical treatment failure, it is recommended to choose the good antibiotics guided by the result of an antibiotic susceptibility testing carried out on the strain isolated by culture or from a gastric biopsy, or with a PCR detecting the mutation responsible for clarithromycin resistance. But culture of this bacteria is difficult, and PCR only detects resistance to one of the 6 antibiotics used to treat these infections. It's not easy. You remember I told you that the vast majority of infected people are asymptomatic. They have no sign of infection, and therefore there is no clinical sign of success or failure of eradication treatment. When the treatment must absolutely be controlled to know whether there is success or a failure in eliminating this bacteria from the stomach. This control is carried out using non-invasive tests such as urea breath test or stool antigen detection. And to know if you are dealing with a resistant strain is because there is a failure in the treatment. The detection of antibiotic resistance is routinely performed after culture of gastric biopsies by determining susceptibility of the antibiotics used for eradication, or by PCR detection, detecting clarithromycin resistance. But culture of this bacteria is difficult. PCR only detects the resistance of one antibiotic, and but in H. pylori, antibiotic resistance is due to mutations in the gene encoding antibiotic targets. Then we need a new tool to detect all this resistance to be able to guide the treatment and to choose the good antibiotics effective against this strain infecting the patient. It could be a good selection, but because I told you that H. pylori antibiotic resistance is due to mutation in gene encoding antibiotic targets, and NGS, new generation sequencing, can detect this mutation directly from gastric biopsies. And this can be an alternative to this difficult culture and antibiotic susceptibility testing. With this new technology, we can promote the guided treatment, which is more effective, cheaper, and with less side effects than the empirical treatment.